Good evening, friends. We are starting with a new series of session, Elite Test Series 2025. This is for NEET SS 2025, which may be held in probably November or December. So today is the first session. I'm starting with Hepato Biliary and Pancreatic System. We are starting with a new series. So I'm starting with Hepato Biliary and Pancreatic System. We have around every week one session. This will be going up to October month end. So you'll be having a lot of sessions based on various systems from Sabiston. So today we are going to discuss the questions of hepatobiliary and pancreatic system. I hope you all have attended the test in Dr. Tutorials app. So a test will be conducted from Friday to Sunday and the discussion will be on Sunday. And the schedule is already displayed in our Instagram channel and other websites. So please go through this. So please answer the question. False about the bile salts. Bile salt maintains osmolality same like plasma. Bile acids are transported from intestine to liver by binding with albumin, and this phenomenon you know very well called as enterohepatic circulation. So the bile salts which are produced in the liver going into the intestine digest the fat, and after completing its function it is transported back to the liver by means of enterohepatic circulation. So after cholecystectomy, excess bile salts may be entering into the colon, and that may be one of the cause for cholecystectomy patients having diarrhea for few months. So few months post cholecystectomy patients may have diarrhea. Please don't forget this point. And liver is a source of bile salts. That's absolutely wrong. Liver is not the major source of bile salt pool. So bile salt pool is mainly by means of enterohepatic circulation. It is mainly by means of enterohepatic circulation. So from what is excreted, only 5% of the bile salt goes in the motion and remaining 95% will go to the liver. So this phenomenon of enterohepatic circulation is a basic subject from your basic science biochemistry books. So the bile salts will be reabsorbed into the liver and it will be secreted again back into the liver. So the bile salt will be like a enterohepatic circulation pool is maintained. So bile salts are cholic acid and deoxycholic acid, which are actually created from cholesterol and secreted into the bile canaliculi as cholate and its metabolic acid deoxycholate. So the liver actually makes only small amount of bile salt pool used on a daily basis because most bile salts are recycled after use in intestinal lumen. Because bile salts combine to form spherical pockets known as micelles. The salt themselves have no osmotic activity. Instead, the cations that are secreted into the biliary tree along with the bile salt anion. So bile salt is an anion, provide the osmotic load to draw the water into the duct and increase the flow to keep bile electrochemically neutral. Because of this reason, bile maintains the osmolality equal to plasma. So bile being an anion pulls the fluid and keeps its osmolality equal to plasma. So after passage in the intestinal tract, reabsorption by the terminal ileum, bile acids are transported to the liver for recycling bound to albumin. Less than 5% is gone out. When sufficient quantities of bile salts reach the colonic lumen, powerful detergent activity of the bile salts can cause inflammation and diarrhea. So diarrhea is a complication of cholecystectomy. Please don't forget this. This is because when the speed of enterohepatic circulation of the bile increases and may overwhelm the ability of the terminal ileum to absorb bile salts. This is one of the reasons when terminal ileum is resected, you have decreased bile salt. So decreased bile salts are seen in terminal ileal resection. And decreased bile salt results in vitamin A, D, E, K deficiency. And all the fat absorption is observed and the patient may have steatorrhea also. Steatorrhea, ADEK deficiency are seen in deficiency of bile salts. So the answer for this question is D. The first question is a classical paragraph from Sabiston. So all the questions I took from directly Sabiston. So the moment you read the paragraph, you go to the Sabiston, every point is there. So this type of Elite test series will help you to understand how you have to read Sabiston. So how in-depth you have to go into the topics, how the questions can come for NEET SS exam, you'll understand from this discussion. So following are the statements of sphincter of Oddi and gallbladder contraction are true except. So this is a question on sphincter of Oddi and gallbladder contraction. So the musculature of sphincter of Oddi. So please understand. That's a duodenum. So this is a sphincter of Oddi. Sphincter of Oddi is guarded by four sphincters. So sphincter of Oddi is actually four sphincters guarding around the ampulla. So there are four sphincters make sphincter of Oddi, and it is always closed. It is always closed, and it can be opened only by cholecystokinin hormone. When cholecystokinin comes there, it opens. So it relaxes sphincter of Oddi. So the sphincter of Oddi is having a resting pressure. It prevents the duodenal contents. So contents from the duodenum will not enter the sphincter of Oddi because of its tight contraction. It will only allow the contents from bile duct and pancreatic duct to enter inside like this. So now let us see the question. The musculature of sphincter of Oddi is dependent on duodenal musculature. So that is absolutely wrong. It does not depend on duodenal musculature. It is a different musculature. So A is a wrong statement. On sphincter of Oddi contraction, on sphincter of Oddi getting contracted or closed, the gallbladder can distend up to 300 ml capacity it can distend. On CCK action, the intraluminal pressure can rise up to 300 millimeters and the gallbladder contracts and pushes the bile out into the duodenum. So vagal activity is less powerful stimulus to gallbladder contraction than CCK. So please understand. So vagal activity also induces gallbladder emptying. Vagal activity also induces gallbladder emptying, but it is a less powerful stimulus compared to CCK. So the wrong answer in this question is A. A is the wrong answer in this question. So let us see the line from Sabiston. An increase in the activity of sphincter of Oddi in the fasting state, whose musculature is independent from the duodenal intestinal wall, increases pressure in the CBD, filling the gallbladder up to 300 ml through a retrograde mechanism. This muscular sphincter normally maintains high tonic and phasic activity, which is inhibited by CCK. The passage of fat, protein, and acid into the duodenum induces CCK, and CCK, as it suggests, causes gallbladder contraction and sphincter of Oddi relaxation with an intraluminal pressure of 300. At the same time, CCK induces relaxation of the sphincter, causing bile flow. So coordinated with the gallbladder contraction, the relaxation of sphincter allows evacuation of 70% of the gallbladder content within 2 hours of CCK secretion. So there is a problem called as sphincter of Oddi dyskinesia. In this problem, gallbladder contracts, but sphincter of Oddi not relaxes. This is a very common topic. Gallbladder contracts, but sphincter of Oddi not relaxes. And after 2 hours on HIDA scan, the content is not entered duodenum. The content not entered duodenum. The HIDA scan has not entered duodenum even after 2 hours. Is a classical diagnostic investigation called as CCK HIDA. To diagnose this problem of sphincter of Oddi dyskinesia, we have a test called as CCK HIDA scan. So the answer for this question is very clear. Answer is the musculature of sphincter of Oddi is not dependent on duodenal musculature. It is a different muscle and this is a different muscle. Please remember, answer is A. So here comes the next question on HIDA scan. So faults regarding HIDA scan used for gallbladder surgery. This is a very basic question, which is even like a NEET PG level question. So HIDA scan, please first of all understand hydroxyimmunodiacetic acid. When you inject, it is taken by the liver and it gets unchanged without any metabolism. It enters the duodenum. So the radionucleotide substance which we are putting into the liver directly goes to the gallbladder, bile, and enters the duodenum. This is a HIDA scan. It's a physiological scan. It is a physiological scan. No anatomical use in this scan. So no anatomical use. It is only to show the physiological flow. It may give a brief anatomy, but not so clear. Does not diagnose stone. Does not diagnose cancer. Then what is the use of this HIDA scan? HIDA scan is mainly to see the physiology in acute cholecystitis, very commonly used MCQ. Acute cholecystitis, after 1 hour of giving HIDA, gallbladder is not visualized. This is a classical investigation. Acute cholecystitis, after 1 hour, gallbladder is not visualized. In CCK HIDA scan, even after 2 hours, the contrast has not entered duodenum. The radionuclide substance has not entered duodenum even after 2 hours. So let us see the points now. Mainly to evaluate the physiology of bile flow. Failure of gallbladder to fill in 2 hours implies cystic duct obstruction in acute cholecystitis. It provides fine anatomical detail. No, it will not provide fine anatomical detail. It will give a brief anatomical detail. It can diagnose the leak, but not the site of leak. Physiological ejection of gallbladder can be studied. So the answer is C. Physiological ejection of gallbladder can be seen. Yes, 1/3 ejection is correct. In 20 minutes, all the complete ejection will be happening within 2 hours. Completely the gallbladder, everything would have been ejected in 2 hours. So although incapable of providing any precise anatomical delineation, biliary scintigraphy, also known as HIDA scan, can be used to evaluate physiological secretion of bile. The injected substance will be processed in the liver and secreted with the bile, allows identification of the bile flow. Therefore, failure of the gallbladder to fill 2 hours after injection demonstrates acute cholecystitis. This is a line from, so this type of question will be coming in exam. So after 2 hours of injection, demonstrate acute cholecystitis. In addition, scan will identify obstruction of the biliary tree and bile leaks, which may be useful in post-operative setting. HIDA scans can also be used to determine gallbladder function because the injection of CCK during a scan will document physiological ejection. This may be useful in patients with biliary tract pain without stones. This is a condition called as biliary dyskinesia. As a nuclear medicine test, the test demonstrates physiological flow, but not the fine anatomical detail. Okay, don't forget this point. The third question is answer C. Which of the following statement is false regarding formation of gallbladder stones? Regarding formation of gallbladder stones. So this is a very basic NEET PG MCQ. Black pigment stones are exclusively seen in gallbladder due to hemolysis. The pigments get concentrated and it is seen only in gallbladder. Okay, it is a gallbladder stone. It is not seen in bile duct formation or not in liver. It is only gallbladder it forms. Supersaturation of bile with a gallbladder dysmobility is one of the most common cause of stone formation. True. Supersaturation of bile. So this is a very important point. I will tell you. So cholesterol crystal formation is inhibited. No, cholesterol crystal formation is stimulated by glycoprotein and immunoglobulins. They are stimulatory factors of gallstones. Stasis in gallbladder like TPN can cause stone. So what is the reason for gallstone? Bile salts act to solubilize cholesterol. Therefore, bile salts and cholesterol should be in a proper ratio. When there is an increase of cholesterol and decrease of bile salt, cholesterol supersaturates and causes cholesterol stone. With respect to cholesterol stones, cholesterol precipitate out into crystals and the concentration in the gallbladder vesicles exceeds the solubility of cholesterol. Crystal formation is accelerated by pronucleating agents. Glycoproteins and immunoglobulins are pronucleating agents. Finally, abnormal gallbladder mobility can cause stasis and can precipitate stones. Therefore, increased stone formation can be seen in conditions with an impaired gallbladder mobility like fasting. Those who are on long fasting, gallbladder stasis can cause stones. People on parenteral nutrition, people after vagotomy, people who use somatostatin analogs, these all people can get gallstones due to stasis. So please remember the answer for this question is cholesterol stone is stimulated by glycoproteins, not inhibited. It is a pronucleating agent. Okay, don't forget this. So the fifth question is already a repeat question. This question is as such is a repeat question asked in NEET SS. So many questions which are asked in NEET SS will be direct paragraphs. So the following are the causes of failure of ERCP in CBD stone except. See, when you go and tell this question to medical gastroenterologists, they will never accept. They will tell I can break any stone, anywhere, whatever I can break now with the ERCP and mother baby endoscopy and all they used to tell. But what is there in Sabiston? A stone which is more than 2.5 centimeter is difficult to break. Up to 2.5 centimeter mentioned in Sabiston. So the A is wrong. So post Roux-en-Y anatomy, you cannot pass ERCP scope, side viewing scope. Impacted stones, multiple CBD stones. See, more than half of the patients are managed by ERCP without cholecystectomy will have a recurrence of symptoms of biliary tract disease. Please remember, anybody coming to you with the CBD stone, it's mandatory you should do laparoscopy cholecystectomy after the CBD gets cleared. So laparoscopic cholecystectomy is must. If you don't do cholecystectomy, again they will develop stones in 50% of the patients. So large stones, 2.5 centimeter, altered gastric and duodenal anatomy like Roux-en-Y, impacted stones, intrahepatic stones, multiple stones are the most common causes of failure of ERCP. These are the common causes of failure of ERCP. So please understand this paragraph is a repeat NEET SS already asked question. So what are the causes of ERCP failure? So please understand ERCP is a very commonly done procedure by medical gastroenterologist. They used to cut the sphincter at which clock position? So using a side viewing scopy, they cut the sphincter of Oddi at what position? Can you tell me? Sphincterotomy done at which clock position? Yes? Yes, many of you are attending the class. Please tell me 11 o'clock or 1 o'clock position. You should not do at 4 o'clock or 5 o'clock. At 4 or 5 o'clock position, if you do, you may injure the pancreatic vessels can get injured. Pancreatic vessels can bleed. Okay, don't forget this. Bleeding is one of the common complications of ERCP when you go for a wrong sphincterotomy area. You should do sphincterotomy at 11 o'clock or 1 o'clock. Very good. So 11 o'clock or 1 o'clock is the best position to do sphincterotomy. Don't go in 4 or 5 o'clock. You may injure the pancreatic vessels. So this is a very commonly asked question. False statement regarding biliary stricture. So bile duct stricture. So bile duct stricture can extend from intrahepatic stricture, hilar stricture, bile duct stricture, distal stricture, etc. So intrahepatic strictures are usually due to ischemic events. True. So when you have ligated hepatic artery ligation, when doing surgery or hepatic artery injury, when you ligate, you can have intrahepatic strictures. Chronic pancreatitis will cause a stricture in the pancreatic part of CBD like this. This is called as Wadsworth syndrome. Wadsworth syndrome is a condition in which CBD narrowing causing jaundice. In case of chronic pancreatitis, this is called as, this will be a narrowed tapered CBD for last 2 to 4 centimeter. Mid CBD stricture is mostly due to iatrogenic. Please don't forget mid CBD is following a laparoscopic cholecystectomy or any bile duct surgery. So endoscopy therapy provides more than 90% success in long term is wrong. So it will not provide 90%. It can provide 50% success. Many times we have to go for a hepaticojejunostomy. So don't forget intrahepatic strictures are usually due to cholangiohepatitis or ischemic events. Any inflammatory or ischemic process along the length of CBD may cause extrahepatic stricture also. So chronic pancreatitis causes a tapering stricture. Strictures at the mid of the CBD is usually due to iatrogenic or post-cholecystectomy. ERCP with the sphincterotomy and balloon dilatation and stent placement is generally regarded as primary treatment for benign bile duct strictures to make the diagnosis and potentially to treat the process. Endoscopy and percutaneous therapy can provide long-term benefits only in 50% patient. When this is unsuccessful, we have to go for Roux-en-Y procedure. Roux-en-Y procedure for the stricture. So the answer here is endoscopy provides 50% success, not 90%. So with this unsuccessful surgical management with anastomosis of the biliary tree to a Roux-en-Y limb has a success rate of 90%. So this biliary stricture means we have to cut up to 5 mm above the stricture. Go 5 mm above stricture. Because the stricture may have less vascularity, cut it 5 mm above the stricture and bring a bowel and do the anastomosis like a Roux-en-Y pattern. Okay, so this is a classical question of biliary stricture from gallbladder chapter. So false regarding the pathological types of cholangiocarcinoma. So cholangiocarcinoma is a favorite NEET SS topic. So there are 3 types of cholangiocarcinoma. The commonest cancer is sclerosing type. It usually appears here only. Sclerosing type is the most common type and it is seen in proximal ducts. That is a common type. The other types which are seen are papillary type and nodular type are usually seen in the distal duct. This is the papillary type. Papillary type and nodular type. So there are 2 more types, that is papillary and nodular. So papillary type is the best prognosis of all the types. So papillary type and nodular type happens in the distal bile duct and are manifested with intraluminal growths. In nodular subtype, a firm mass based in the duct wall can be seen growing into the duct lumen, whereas the more common papillary subtype in the distal appears as a polypoidal lesion, soft with less periductal fibrosis. So periductal fibrosis is less with papillary type. So sclerosing type is most common in proximal duct. So you all know very well what is the most common site of cholangiocancer. Cholangiocancer is most common site is Klatskin tumor. Klatskin tumor means it is most commonly seen in hilum. The hilum. Therefore, the commonest type is sclerosing type. Nodular type has less periductal fibrosis is wrong. Answer is B. It is papillary type which has less periductal fibrosis. Papillary type is common in distal bile duct. Papillary type has best prognosis. So the answer for this 7th question is B. Okay, don't forget cholangiocarcinoma. So cholangiocarcinoma, I have put another question. Management of type 2 hilar cholangiocancer. So here you should know the classification by Bismuth correlate. So Bismuth correlate has made an extraordinary classification of bile duct cancer. So let us assume what is type 1. Type 1 is a cancer which is seen away from the hilum. This is type 1. So type 2 is a cancer at the level of hilum. It is at the level of hilum. That is type 2. So 3A is a type which is involving 3A is involving the second order ducts. This is 3A. From the hilum, it has gone into the right side second order ducts. 3B has gone into the left side ducts. 4, you should not forget, 4 is a cancer which has gone to both sides. So type 4 is bilateral second order ducts, which is an inoperable cancer. Second order duct, so it is inoperable. So 1 is away from the hilum, 2 is at the hilum, 3A towards the right side, second order, 3B towards the left side, second order. So this is a Bismuth correlate classification. They're asking type 2 cancer, how will you treat? So type 1 and type 2, please understand, type 1 and 2 are easy to treat. We can just do bile duct excision. Bile duct excision with a margin of 5 mm margin. 5 mm margin you can excise. But the very important line is, for type 2, which is sitting exactly over the caudate lobe, we have to remove the caudate lobe also. So that is very important. So 3A, extended right hepatectomy done. 3B, extended left hepatectomy done. 4 is inoperable. So 3A means extended right hepatectomy. 3A is right side, 3B is left side. Okay. 3A extended right hepatectomy is 4, 5, 6, 7, 8 along with 4A plus 4B removed. Extended left hepatectomy is for 3B type. We have to remove 4A, 4B, 2, 3 plus 5 and 8. So these are the surgeries. Please understand. Type 3 lesions involves complex resection and reconstruction may be needed for portal vein, hepatic artery or both. With resection of secondary biliary radicals, trans-anastomotic stenting is used liberally to allow the healing and even confirmation of anastomotic integrity. People used to put a trans-anastomotic stenting. A substantial improvement in long-term survival has correlated with the increasing use of hepatic resection to achieve negative margin, because negative margin status is the most important prognostic factor. So please remember, negative margin is the most important prognostic factor of bile duct cholangiocancers. Okay, don't forget this. They are the questions. I took some 8 questions from gallbladder and biliary system. So please come back to pancreatic chapter now. So regarding the pancreatic organogenesis, one of the questions which I put here will be looking more pathological, but this question is a direct repeat of NEET SS. This is a direct repeat of NEET SS. That is why I put this table. So all the tables in Sabiston is important. There will be questions from all the tables. So regarding the pancreatic organogenesis, false statement is PDX1 gene. See, PDX1 gene is involved in exocrine differentiation. Exocrine part of pancreas, which produces enzymes and bicarbonate, that is by PDX1. So lack of WNT signaling results in pancreatic agenesis. So please understand. So WNT signaling is important in all parts of pancreas development. Lack of WNT signaling results in varying degrees of agenesis. So please remember a few basic things. PDX1 involved in exocrine production, and WNT loss results in agenesis of pancreas. Very important. Agenesis of pancreas. Hedgehog is a very important concept. That is a usual question. Hedgehog inhibition in PDX1 positive cells leads to initiation of endoderm differentiation. See, please understand, inhibition of hedgehog. Inhibition of hedgehog stimulates endoderm differentiation. So previously PDX1 is doing exocrine. Now inhibition of hedgehog in PDX1. So in other words, inhibition of PDX1 inhibition causes endoderm production. But here it is mentioned, in hedgehog inhibition in PDX1 results in inhibition is wrong. It is stimulates endoderm differentiation. Okay, don't forget endoderm differentiation. And finally, PAX4. Please see this point. PAX4 expression of beta cells and gamma cells. Okay, beta cells and delta cells. PAX4 helps in beta. Little difficult table because it's not a surgeon's concept, but you have to know hedgehog. Hedgehog inhibition of PDX1 causes endoderm differentiation. PDX1 causes exocrine differentiation. So PDX and hedgehog are very important things. PAX stimulates beta cells to produce insulin. So don't forget these points. So the answer here is C. False statement regarding pancreatic juice exocrine function. This is a very common MBBS level question. Exocrine functions of pancreas, which is nothing but production of all the enzymes in a proenzyme form. All the enzymes in pancreas are produced in proenzyme form. They get activated by enterokinase. Once they enter the bowel, they are activated by enterokinase. Let us see about it. Enterokinase produced from the duodenal mucosa catalyzes the enzymatic activation of trypsin from the proenzyme trypsinogen. Pancreatic lipase hydrolyzes the fat into free fatty acids and 2 monoglycerides. Premature activation of trypsinogen is done by SPINK1. It is wrong. It is premature activation of trypsinogen is done by SPINK1 is wrong. It is SPINK1 is actually prevents the premature activation. Prevents premature activation. Please don't forget premature activation. So the answer here is C is a wrong answer. So optimal pH for the pancreatic enzymes to function is 8 to 9. So please understand the duodenal mucosa expresses enterokinases on its brush border, which catalyzes the enzymatic activation of trypsin from trypsinogen. Trypsin plays an important role in protein digestion by propagating protein pancreatic enzyme activation through autoactivation of trypsinogen and other proenzymes like chymotrypsinogen, procarboxy, proelastase. All these are produced. Pancreatic lipase, which is stimulated now, hydrolyzes the fat into free fatty acids and 2 monoglycerides. In addition to pancreatic lipase, acinar cells produces enzymes that digest fat but are stored as proenzymes. These include colipase, cholesterol ester hydrolase, phospholipase A2. The main function of colipase is to stability the activity of pancreatic lipase. Pancreatic enzymes are inactive. This is an MBBS topic. Are inactive inside the acinar cells because they are synthesized and stored in inactive enzyme. In addition to this autoprotective mechanism, acinar cells synthesize pancreatic secretory trypsin inhibitor. Trypsin inhibitor, which also protects acinar cells from autodigestion, and because it counteracts premature activation of trypsinogen inside the acinar cells. So this trypsin inhibitor is given by a protein code called as serine protease inhibitor causal type gene, SPINK gene. So SPINK gene mutation causes, if it causes childhood pancreatitis, like hereditary pancreatitis can happen. It is associated with hereditary pancreatitis. It is associated with chronic pancreatitis. So many cases of pancreatitis have associated SPINK1 mutation. There are many genes like PRSS, etc. But SPINK1 is one of the important mutation which is seen. So pancreatic bicarbonate, which is produced by the pancreas, is having a high help in making the enzymes more active. So pancreatic enzyme optimal function of trypsin is 8 to 9. And for lipase is 7 to 9. Okay, amylase is 7. So most of them are active in alkaline pH. So they have needed alkaline. That is one of the reason when we give pancreatic enzyme supplements for pancreatitis patients, we should give them along with pantoprazole. Without pantoprazole, if you give pancreatic enzymes, all the enzyme tablets will be no use. Please understand this. So crayon, panlipase, everything you should give along with the pantoside only. Okay. So regarding amylase and lipase, true statement is threefold or higher elevation of amylase and lipase in serum is a diagnostic criteria. So amylase or lipase elevated 3 times, you can diagnose it's a pancreatitis. Amylase is having only 10 hours of life. Lipase has around 7 to 14 hours. Just remember as 7 to 14. Amylase 10, lipase 7 to 14. And amylase normalizes in 3 to 5 days. And lipase normalizes not in 1 month. It is very long. It will normalize in 1 week. It can be elevated up to 1 week also. So C is wrong. So lipase is more specific and sensitive. So in patients who do not present to emergency department in first 24 to 48 hours after the onset of symptoms, please remember amylase will not be helpful. So determination of lipase level is more sensitive indicator to establish the diagnosis, and it is also a specific marker because amylase will be elevated in peritonitis, peptic ulcer, many other cases will be elevated. So therefore, please remember lipase is more specific, more sensitive. So this is again a NEET SS repeat question. Some questions are repeat questions I have put here, so that you will understand how the pattern of question was asked before. Regarding the management of Gallstone pancreatitis, consensus says except. So for a Gallstone pancreatitis, please understand there are 2 interventional procedures done. Number 1 is ERCP. Number 2, laparoscopic cholecystectomy. So ERCP, will you do for all cases? No, not done for all cases. Then for whom will you do? Those patients who are having cholangitis. Those patients who are having cholangitis, I will do an EUS, and if I find out there is a CBD stone, please understand, if I do a cholangitis case, if I do EUS and that is showing me a stone in the CBD, then only I will go for ERCP plus sphincterotomy. Otherwise, no role of ERCP. In pancreatitis, it doesn't have a role. ERCP as such does not help in pancreatitis. It helps only in associated cholangitis. Carry home point. So laparoscopic cholecystectomy is must. Otherwise, patient will again develop pancreatitis. So therefore, what should I do? In mild cases, I will do lap cholecystectomy in same admission. Same admission you should do. In severe cases, you should do it after 6 weeks because patient is sick now. Let me do after 6 weeks. So, sir, the patient is totally unfit for lap chole. What should I do? In this patient's ERCP plus sphincterotomy is another option without cholecystectomy. So ERCP and sphincterotomy can be done for these patients, selected patients who are unfit for laparoscopic cholecystectomy. I can do an ERCP, and sphincterotomy can be done only for those cases. So this is a very interesting concept which I have explained here. ERCP has no use in acute pancreatitis, whatever may be the severity. True statement. ERCP is done only if EUS demonstrates bile duct obstruction. Laparoscopic cholecystectomy is advised at 6 weeks for mild. No, it is wrong. For mild case, immediately. For severe cases, after 6 weeks. Without cholecystectomy, 30% of the cases will recur. Therefore, cholecystectomy is a part and parcel of acute pancreatitis due to gallstones. So only option is those who are unfit for laparoscopic cholecystectomy, we can do ERCP and sphincterotomy. That is what I explained here. Please go through the explanation given in the MCQ material of your app. So the following are included in major criteria for Rosemont. This is a new update. In Bailey and Love, they have added everything about Rosemont criteria. So Rosemont criteria is a very important criteria from Sabiston. It's a really difficult topic to be mugged up. So I can only tell you just remember the major criteria of the duct. So this the pancreas means pancreas have duct and parenchyma. So major criteria of the duct and parenchyma you remember. So major A criteria in the duct is calculi is a major criteria, number one. Parenchymal criteria is hyperechoic foci with the posterior acoustic shadowing is nothing but a stone. Major B criteria is honeycombing lobularity like this. So this is honeycombing. So honeycomb, stone in the parenchyma, stone in the duct. These are the three major criteria. Minor criteria or full list is there. So we cannot mug up all those things. Very difficult. But I can tell you the following are major criteria except parenchyma showing hyperechoic foci means there is a stone. Honeycombing is present in the parenchyma, main pancreatic duct, and pancreatic cyst is a minor criteria. I didn't put that table. There is a full table showing you major and minor criteria. So parenchymal features of major criteria. Major A is posterior acoustic shadowing. Major B is honeycomb. And major A in the duct is a huge stone. Just remember this alone might be asked in your exams. So very favorite MCQ for NEET SS exam is a cystic neoplasm, mucinous neoplasm of pancreas. And you know, cystic neoplasm is too much updated in Bailey and now 28th edition. More detailed update is there in Bailey than compared to Sabiston. That much they have added in Bailey and Love this year. So now mucinous cystic neoplasm, it is most common in the body and tail of pancreas. It is common in the body and tail of pancreas. It will have an eggshell calcification on CT scan. It is common in females than males. It has a ovarian stroma on biopsy. Fluid analysis shows CEA increased, amylase normal on fluid analysis. Okay, biopsy shows ovarian stroma and it is mostly malignant. Therefore, we should always go for surgery because it is mostly malignant lesion. So, and point number, very important point here is compared to ductal cancer versus mucinous cancer, which has bad prognosis. Ductal cancer has bad prognosis. Mucinous cancer has good prognosis. Okay, this is a very basic question. Ductal cancer is a bad cancer. Please don't forget this. So biopsy shows ovarian stroma. CT shows eggshell calcification. CEA elevated 192 or more. And prognosis of mucinous neoplasm is very poor than ductal cancer is wrong. Prognosis of mucinous is good than ductal cancer. That is what explained in the theory. So please go through. Invasive mucinous neoplasm exhibits slower growth, less frequent nodal involvement, and less clinical aggressive behavior compared to ductal cancer. A 5-year survival is 50 to 60%. 50 to 60%. So the point is MRCP suggesting stone was once upon a time given in book. So ERCP showing, so Shailesh is asking it out, sir, cholangitis with MRCP suggestive of CBD also need ERCP. The point is, what is given in Sabiston is we have to verify in EUS whether there is a CBD stone. In nowadays in JIPMER and many other institutes, they always do EUS before ERCP. EUS is now a mandatory test before ERCP. As you are telling, we are doing in our institute and all only MRCP because we don't have EUS. So we are doing MRCP, then only we are going for ERCP. So we used to tell MRCP is a roadmap for ERCP. It is changing. It is now changing. In future, the textbooks will never mention MRCP is mandatory before ERCP. They will mention EUS is mandatory before ERCP in future. As of now, what is there in Sabiston is they are mentioning EUS should be done. If there is an obstruction, go for stenting. Okay, there is no obstruction, but it is not mentioned in MRCP. See the line. ERCP is only indicated for patients who develop cholangitis and those with persistent bile duct obstruction demonstrated by other imaging modalities such as EUS. So other imaging modalities you can also consider MRCP. But the best is EUS. Okay, don't forget this point. So now this question answer is prognosis of mucinous neoplasm is not bad. It is good. And this is a very basic question. Most of you will be answering borderline resectable cancer. The following are the concepts of borderline resectable cancer is a very favorite question again. So let me show you what does this mean by borderline resectable. So all of you know this is superior mesenteric vein entering the tunnel of love and becoming a portal vein. So this is superior mesenteric vein, portal vein axis. So, and this is a superior mesenteric artery, which is just running on the uncinate process level. This is superior mesenteric artery. And what are other arteries very nearly related? So, this is another artery very closely going on the superior border of pancreas from the celiac artery. This is celiac artery, and this is common hepatic artery. So, therefore, a cancer in the head of pancreas, can infiltrate any of these vessels. If it infiltrates superior mesenteric vein, portal vein, SMV portal vein infiltration more than 180 degree, or SMV portal vein with a thrombus, but it is less than 180 degree infiltration. So, SMV portal vein more than 180 degree engulfing, or there is a thrombus in the vein with a less than 180 degree infiltration, or it has infiltrated superior mesenteric artery less than 180 degree. So, it has gone to the superior mesenteric artery less than 180 degree, or it has gone to the common hepatic artery in such a way I can cut and do reconstruction. So, reconstructable manner. Infiltration in a reconstructable, all these are called as borderline resectable. So, borderline resectable are superior mesenteric vein or portal vein more than 180 degree, superior mesenteric vein or portal vein with the thrombus less than 180 degree, and superior mesenteric artery less than 180 degree, or common hepatic artery infiltration which is in a reconstructable manner. These are all points. So, common hepatic involvement which has gone up to the celiac artery is inoperable. So, is inoperable. Up to celiac artery is inoperable. That is not reconstructable also. That is called as so what is unresectable? So, unresectable means very simple, very easy to remember also. Unresectable means superior mesenteric artery involved more than 180 degree. Number 1. Number 2, celiac artery infiltration. Number 3, common hepatic artery in a non-reconstructable manner. So, these are all called as unresectable. So, only this is unresectable. So, for borderline resectable tumors, we should start them on neoadjuvant chemotherapy and reassess after 3 months. So, please go through this. What is about the involvement of the vessels? Solid tumor in contact with the common hepatic artery without extension to celiac axis or the hepatic artery bifurcation. So, that means what? If this is a common hepatic artery, infiltrated only common hepatic artery, not gone to the bifurcation, not gone to the celiac artery, means I can cut and reconstruct. If it infiltrated to bifurcation or to celiac artery, it is inoperable. Okay, that is a point. Please go through this slide, you will understand. So, 15th question. This is a classical question because many times we have a basic rule. What is the minimum number of nodes removed in various cancers? So, when you discuss minimum nodes in cancer is a very common discussion. For example, gallbladder, you should do 6 nodal dissection. Esophagus, you should do 15 nodal dissection. Stomach, you should do 16 node. Small bowel, 8 node. Colorectal cancers, 12 node. Breast cancer, 10 nodes. Like this, each cancer has a number of nodes. So, a basic number of nodes should be removed is a common concept in oncosurgery for each cancer. The interesting point is, what about pancreatic cancer? So, regarding the extent of lymphadenectomy for cancer pancreas, when we are doing Whipple's or when we are doing distal pancreatectomy, whichever cancer you do for pancreas, what is the concept? Standard pancreatectomy is the operation of choice. There is no need of regional pancreatectomy. There is no need of extended lymphadenectomy. Nothing is needed as per Sabiston. You can read the lines. In addition to the peripancreatic, portal, pyloric lymph nodes, extended lymphadenectomy includes retrieval of hilar retroperitoneal nodes extending from celiac to the level of inferior mesenteric artery, and several randomized control trials have been completed with no evidence to suggest improved survival after the extended lymphadenectomy. So, extended lymphadenectomy, no use. In fact, more than one trial has shown increased morbidity associated with the extended lymphadenectomy, including delayed gastric emptying, pancreatic fistula, and dumping. So, therefore, current evidence is standard pancreatic duodenectomy. There is no number of nodes needed. So, whichever node is coming along with the Whipple's, that's okay. There is no need of nodal dissection specifically for Whipple's. That is a point you should not forget. So, I hope those who wrote NEET SS 2024 will be remembering this question. It is a question out of syllabus from Sabiston, from spleen. So, we are making material from SWOT's updates. So, please go through those updates alone from the app. Whichever not in Sabiston, which is there in SWOT's, we are making a separate video from all the subjects. So that question came from Swartz in NEET SS 2024. The following are included in second line treatment of ITP. So even I have read Bailey and Love, Sabiston, I have not heard a line like this, second line treatment of ITP. When I saw the question review, I also thought it might be something like a splenectomy, etc. But when I went into Swartz, the chapter is explained differently. First line therapy of ITP is oral prednisolone. All of us know this. And IV immunoglobulin in pregnancy and all, we give IV immunoglobulin during some other surgery or some other time, we can even give IV immunoglobulin. So the first line treatment is oral prednisolone and IV immunoglobulin. Only these two are the first line treatment. Then what about second line treatments? Second line treatments are mentioned. Splenectomy is mentioned as a second line treatment. Rituximab, anti-CD220 antibody is mentioned as a rituximab. Thrombopoietin receptor agonist, like I hope you know, romiflastin, L-thrombopac. All these are which will stimulate platelet production. So these are all second line treatment. So second line treatment includes splenectomy, rituximab, thrombopoietin antagonist. So which is not the second line treatment is following are included in second line treatment except immunoglobulin. Immunoglobulin is coming under first line treatment, and rituximab, L-thrombopac, all this come in second line treatment. So it's a new question, only seen in SWOT. There is no such first line, second line heading in Sabiston. Okay. So this is a question very commonly asked from INI SGE question. This is a very commonly asked INI SGE question. Same table, the same picture is also there in Bloomgart. Most common anomaly of bile duct confluence insertion. Every lap surgeon doing laparoscopic cholecystectomy must know this anomaly. So the commonest finding you see is this, that is only in 57 patients. 57 out of 100 patients will have the normal right anterior, right posterior, left hepatic duct. Second, please see among the various anomalies mentioned, there are the commonest anomaly is C. C is 20%. What is C? 20%. C is an anomaly of right anterior and right posterior joining common bile duct. Please understand. So right anterior sectoral duct and right posterior sectoral duct joining the common bile duct. In this, if you see, this A is C1 is right anterior sectoral duct anomaly joining into the common. So this is right posterior sectoral duct joining the common duct. So right anterior, right posterior. This is right anterior, this is right posterior anomaly. So this is among this, which is common. Right anterior is 16%. Please understand, right anterior is 16%, right posterior is 4% only. So this right posterior duct mimics like cystic duct. Many times we clip this right posterior duct thinking it is a cystic duct. That is why we have to do the critical view of Strasberg. Don't forget it. And this B is very interesting. See, B is nothing but triple confluence. It is like a 3 ducts joining at the confluence. So B is 12%, that is triple confluence. There are other anomalies go through D1, D2 or nothing but right anterior duct joining the left duct. So joining left hepatic duct is called as D1, D2. So E1, E2 or other very rare anomalies, absence of confluence in E. There is no confluence at all. There will be multiple method of joining. And F is a condition in there is absent of right hepatic duct and ectopic drainage of right posterior duct into cystic duct. See, this is a posterior duct drains into cystic duct. So luckily, these anomalies are very less than 2%, less than 1%, less than 2%, less than 5, 1. So luckily, you won't see this D, E, F in your practice. So if your time is good, you will never encounter these injuries. But commonly encounter anomaly is right anterior and right posterior entering into the common duct. Please don't forget this table from Sabiston. The commonest anomaly is right anterior sectoral duct inserting into right common hepatic duct is 16%. That is what C1 from the image. Please go through this image. This is an image from Bloomgart as well as in Sabiston. So regarding hepatic function test, false statement is aminopyrin test is based on cytochrome P450 clearance. These are all old tests, which is outdated test. I think in Sabiston 22nd edition, probably they will remove all these things. So we hope it will be removed. That will be better because instead of mugging up all these things, aminopyrin is based on cytochrome P450. Lidocaine is also based on cytochrome P450 with the measurement of MEGEX will be done. Galactose elimination test is based on liver's role in phosphorylating glucose, and indocyanin D is metabolized in the liver and excreted please understand, indocyanine grease without any metabolization, it is taken by the liver and excreted. No metabolism happens. So these are all for hepatic function test. So please remember, these hepatic function tests are all once upon a time done. Everything is now replaced by nuclear imaging studies. So I'm telling you, this paragraph is very big, but no use. What you should carry home is aminopyrin test based on cytochrome P450. Lidocaine test is based on cytochrome P450. And when I use lidocaine, there is an advantage I can use to measure one metabolite called as MEGEX. And indocyanine is a dye removed by the liver by a carrier-mediated process and excreted in the bile. It is not metabolized, it is rapidly excreted in the bloodstream. This is the only test that has been found to have some prognostic ability in cirrhotic patients undergoing liver resection. But no institute is doing all these tests. All of them are now doing technetium 99M, galactosamine, human serum albumin scintigraphy, and technetium 99M mebrofinin hepatobiliary scintigraphy. This helps you to identify FLR most accurately. FLR is diagnosed most accurately. Not only FLR volume, but also the FLR function also can be detected. All these are major advantages of technetium nuclear scans. So everything is now replaced only by nuclear scan. But since this is a paragraph from Sabiston, I took this paragraph. See, without any consideration, I took paragraphs from Sabiston because all of them can come for you as an exam. So the examiners, I know the examiners, they just prepare only from the book. They don't use any previous Q bank. They don't use any Q bank. They just open Sabiston and they know how to prepare one question from one paragraph like this. This is how they prepare and this is how the questions will come. Therefore, it will be better if you can read line by line from Sabiston. If you read line by line from Sabiston and you're very strong in the concepts of Sabiston, I'm telling you, you'll be within the first 10 ranks. If you're unable to read Sabiston line by line, you can go with the duct tutorials. I can assure you, you will be within the top 200 ranks. So that is very important. So Sabiston or duct tutorial platform, which one of this will guide you to get within top 200 rank. But duct tutorials, question materials and question bank, you should read line by line. Okay. So false regarding the partial shunt operation. Actually, that is a wrong. Actually, in the app that is being mentioned wrongly because it is right posterior duct into the left hepatic duct is the commonest anomaly. It is wrong. So because the doubt I also had when I'm verifying. Then I went into this table from Bloomgard. So this is a Bloomgard choice. So in this, according to this, if you see which is the most common percentage, I went into C1. So probably that question might be from some old edition books or I don't know what is it. But present edition, the most common anomaly from this list you can see C1 is mentioned in this list. And they never mentioned anywhere this is the most common anomaly. I am mentioning that based on the percentage given in Sabiston as well as Bloomgard. This is seen in both the books. This is a classical picture from both the books. And yes, I also saw that MCQ. Probably that MCQ was an old book recall. I don't think that should be answered now. So please go with this. What is there in Sabiston? So partial shunt, I hope you know what is this shunt. It is surface shunt, which is only 8 millimeter. The normal shunt between the IVC and portal vein will be around 10 to 15 millimeter. But this is a small shunt called as partial shunt, which preserves the blood flow. Partial shunt is a smaller shunt. Hepatic portal perfusion is preserved. Thrombosed shunts can be opened by interventional techniques. 8 millimeter versus 16 millimeter shows similar encephalopathy and survival in both. So both does not have same encephalopathy. So 16 millimeter will have more encephalopathy, 8 mm will have no encephalopathy. This picture, question number 8. 18, A and D. No, actually, right. D answer is right posterior sectoral duct inserting into left duct. So that is different. This is D1. This is D choice is D1. So this question is a little complicated question, very difficult for anybody to remember and retain. I'm telling you that from the picture, which is 16%, go for right anterior sectoral duct draining into the common duct. So just go for it. That's all. So in the app, it is giving 4th option. So I think it may be typed wrongly in the answer. So you can clearly see from here. So this is C1 is the commonest. Okay, C1 is the commonest. Right anterior duct draining into the common duct. That is the commonest anomaly from the table, from the picture. I'm not answering from the lines. There is no statement in the book. From the picture, I'm answering the question. I made the question from the diagram. So this answer is D. So the question here is surface shunt has less incidence of encephalopathy, and in surface shunt, hepatic perfusion is preserved. Therefore, now instead of doing a bigger shunt of interposition of 16 millimeter, you can go for 8 millimeter surface shunt. It acts like a selective shunt, like a Warren shunt. It acts. It's a surface shunt. Okay. Even if it gets thrombosed, you can easily do a stenting into the. That is what mentioned in this. Okay. So regarding the management of pyogenic liver abscess, true statement is, it's a simple straightforward question from Sabiston. Broad spectrum antibiotics are started after culture sensitivity. No, you cannot wait for culture sensitivity. You have to start antibiotics immediately and send for culture sensitivities, blood sample taken and start an antibiotic with higher coverage. Let the sensitivity come, after that we'll change the drug. So start it. And antibiotics are done for 7 days is wrong. It should be given for 14 days. PCD, percutaneous drainage with a pigtail catheter, is the treatment of choice for most patients. PCD and aspiration both have similar success rates. Naturally, you know, when I put a pigtail catheter, it has much better much better result than a aspiration by a needle. So the answer is C is the treatment of choice. All other things are wrong answers. So percutaneous catheter drainage has become the treatment of choice for most patients. Relative contraindication to percutaneous catheter drainage is a repeat MCQ. It includes ascites, coagulopathy, and very close proximity to vital structures like intrahepatic artery or intrahepatic portal vein. It should not be put. Percutaneous drainage of multiple abscesses is usually met with higher failure, but reports have demonstrated a high enough success rates that percutaneous approach should be made first, reserving surgery for failure cases only. In general, surgery should be reserved for patients who undergo surgery for some other pathology. Otherwise, you should go for percutaneous drainage. So success rate is 60% in aspiration group, 100% in catheter group. Please don't forget this. Aspiration means only aspirating. Catheter means percutaneous pigtail catheter. Okay. MCQ 11. What is MCQ 11? So, okay. I think a true statement is all except is missing in this question. 11th question, all except is missing. So answer is C. Yes, correct. Thank you, Srijan. So here the answer is all except C. The except is missing in 11th question. Please change the question. Except is missing in 11th. The except question will be always asked in NEET SS. So there will be no question on true statement usually. There will be questions will be made. The following are true except. So recurrent pyogenic cholangitis, a favorite NEET SS topic again. So recurrent pyogenic cholangitis is a oriental cholangiohepatitis seen in Chinese people. It is due to clonarchy sinuses and many other infections. So it is a symptom of repeated attacks of cholangitis secondary to biliary stones and strictures that involves extrahepatic and intrahepatic ducts. People call it also as oriental cholangiohepatitis or hepatolithiasis. It is exclusive to Asians. Men and women are equally affected. Historically, that it is common in 20 to 40 years. The cause is unknown, but recurrent infection of the biliary tree may be associated. Ultimately, stones and strictures develop in the biliary tree, and we don't know which is forming first, whether a stricture or a stone, but both are seen, and all the stones are brown pigment stones. So association of recurrent pyogenic cholangitis and clonarchy sinuses ascaris has been noted. And strictures can be found anywhere, but usually involve intrahepatic main duct, most commonly on the left hepatic duct. That is the most important MCQ. Recurrent pyogenic cholangitis have left side intrahepatic duct stricture. Cirrhosis and liver failure are seen. Other complications include fistula, pancreatitis, and cholangiocancer can happen in future. So please remember the answer here is strictures are mostly seen on right side duct is wrong. It is seen on most common on left side duct. RPC is common on left side duct. Okay. 23rd question on liver cell adenoma and mutation. So please remember the one basic question for lifetime. Liver cell adenoma, if they have beta catenin mutation with an exon 3 mutation, they will go for HCC. So HCC is seen in beta catenin mutation with a exon 3 mutation. So highest malignant transformation is seen in HNF1A mutation is wrong. Sonic hedgehog mutation causes bleeding and obesity. Exon 3 has HCC. Exon 7 has no HCC. So in beta catenin, exon 7 or 8 does not have HCC. Exon 3 has HCC. Sonic SHH mutation causes bleeding and obesity. Otherwise, there are so many types of molecular types of this adenomas are given in Sabiston, like beta catenin type, HNF1A type, inflammatory type, and there are so many types. Highest malignant transformation is seen with beta catenin, especially exon 3 have highest risk of hepatocellular cancer. So the following are the features of fibrolamellar HCC except. So this is again a NEET PG question. So male is to female is 1:1 ratio, young age, AFP is usually not elevated. The tumor marker elevated is neurotensin B. But there is a table in Sabiston mentioning AFP is positive in 5%. Therefore, I'm thinking this also is correct. Usually it is not elevated, but table says 5%. Recurrence is the major issue of fibrolamellar type. So fibrolamellar type, the most important problem is recurrence. So recurrence is more common. Okay, it is more common. So tumor commonly occurs in younger patients with history of cirrhosis, without history of cirrhosis, and they also have a central stellate scar like FNH. So like FNH, they also have a central stellate scar, and fibrolamellar HCC does not produce AFP, but elevated neurotensin B is seen. And because the liver is normal, you have a good prognosis, and long-term survival depends upon recurrence. Recurrence is common and occurs in 50% of the patients, and lymph node metastasis predicts a worst outcome in these patients. Clinical score for colorectal cancer meds called as Fong's clinical score. This is a 100 times repeated NEET SS question as well as INI SS question. Colorectal cancer meds have, yes, HUDs and limb access and all is done for recurrent pyogenic cholangitis. So Fong's clinical score is a repeat MCQ. Disease-free interval of less than 12 months, CEA more than 200, disease-free interval of less than 6 months is wrong. Size of the tumor is more than 5 cm, which is wrong statement is answer is disease-free interval 6 months is wrong. So note positive primary, disease-free interval less than 12 months, more than one tumor, size more than 5 centimeter, carcinoembryonic antigen more than 200. This is an improperly framed question, so just don't worry. Whichever is not seen, these are the 5 points, 5 scores. We have to give 1 point for each, and more points, more bad prognosis. More than one tumor, tumor size 5 centimeters, CEA elevated to 200. And disease-free interval less than 12 months, the patient had a recurrence of liver mets. So node positive primary when I operated. All these are given 1 point, and this is called as Fong's clinical score. So that completes the HBP elite test series. All the test series will be going like this. By concerned faculties of concerned specialty will be doing all the test series. We have given the full schedule of the test series along with the faculties who are going to take, and we will be conducting the test will be conducted on Friday of every week in the app. Friday to Sunday you will have the test, and Sunday you will have discussion. This is the plan of the test series, elite test series, and already we have done a lot of elite test series like this previously also. This is again the fourth session. This is we are doing here. Already we have done 3 sessions. Those videos are also available. If you have time, you can also go through those videos. So thank you all for attending the session and for most important interactions. So time to complete. Thank you.